incision was made on the mucal gingival junction. A vertical incision was made distal on 29 area and mesial of 28. A split thickness incision was made from the mucal gingival junction to the vestibule to prepare the recipient's site for the free gingival graft. Being very careful at this time to not accidentally lacerate the mental nerve. Using the periosteal elevator to remove some of the mucosal attachment to place the free gingival graft on the bone. I find the graft is more stable when placed on bone instead of a movable mucosal bed. When there's an option to place the graft on the bone or the periosteum, I prefer to place on bone as much as I can. The second purpose for using the periosteal elevator to dissect the periosteum away is to make sure I do not encroach on the mental nerve area. Once the recipient's site was prepared, I used a periodontal probe to guesstimate the approximate size of the donor tissue necessary to harvest. In this case, about 12 to 15 millimeters in length and 5 to 6 millimeters in width was chosen. I make 4 puncture wounds with the periodontal probe. I usually make the incision not deep where I touch the bone. Making a bevel incision at the cortical portion of the donor site, leaving some connective tissue on the palatine bone, usually about 1.5 millimeters thick. I am placing Surgicel, which is a resorbable collagen, hemostatic tissue, and I'm using 4O silk sutures to stabilize the Surgicel on the palate. I try to create pressure by creating tension to achieve good homeostasis. I like to use Surgicel. Some doctors just leave the donor site alone or use Vaseline, and some use sutures to achieve homeostasis. It's all personal. I'm placing the donor tissue on different orientations to see which orientation would be the best fit for this recipient site. I usually like to suture the 2 corners first. I am using 5O gut sutures with P2 needles. All that's really needed is 1 suture in the center of the graft and 2 sutures on either corners, but I personally suture as much as possible.
What is this, chronic? Yeah, chronic.
In order for angiogenesis to occur, the goal is to have 0 movement of the donor tissue. I check this by performing this movement of the mucosal tissue. If there's any movement of the graft, it will not be stable. Here is the palatal site. I'm placing a nice piece of Copac or periodontal dressing to cover the donor site so the patient can feel comfortable enough to eat some soft food. And again, this is personal to me. Some people don't put anything over the palatal site, and some people put a plastic stent, but I found a big piece of periodontal dressing works well for me. This will remain for 1 week until I take it off. I make sure that before I put the periodontal dressing, the area is very dry, so it sticks to the tissue. I adapt it to the crevice of the gingival embrasures so it locks in, and I wrap it around the distal of the molars. I use the Edentulous area as a way to wrap around the lingual, and I make sure it locks interproximally so it doesn't detach. I try to avoid any sharp edges of the Copac on the soft tissues during the healing period by border molding like I would with dentures, moving the patient's muscles mesially and distally.